Welcome to the deep dive. Today we are tearing into what is really the absolute bedrock of pharmacology.
There really is.
We're not just talking about what drugs do. We're talking about
Yeah.
this constant dynamic conflict between the medicine you take and how your body actually reacts to it.
That's the core tension, exactly. If you've ever wondered, why one drug works in minutes and another takes days,
Or why the dose is completely different if it's an IV versus a pill.
that's it. The answer is always in these two huge concepts. First, pharmacodynamics, which is how the drug affects the body, and then pharmacokinetics, how it fights back.
So our mission today is to get a really quick, solid grasp on these high-stakes mechanics. Because understanding this balance, this push and pull, is the real shortcut to being truly informed about your medicine.
It governs everything: dosing, timing, safety. It's all there.
Okay, let's unpack this first one. Pharmacodynamics, it's about how that chemical messenger actually changes things inside a living system. What's the basic game plan for a drug?
The strategy is surprisingly simple at its core. It's interaction. Drugs either, one, replace something that's missing, think insulin,
Right.
or two, they just modify what's already happening. They can stimulate cellular activities, ramp them up, or three, they can depress them, slow them down, like a sedative.
And the fourth word is different.
The fourth one is different. It interferes with foreign cells. That's what we call chemotherapy, in the broadest sense.
And the main way this all happens is that famous lock and key analogy.
Exactly. We're talking about receptor sites. Just think of them as specific protein areas, little docking stations, usually on the outside of a cell.
The drug is the key.
And drug is the key. If it fits the lock, the receptor, the cell gets a signal and responds. And that leads right to our first critical distinction between agonists and antagonists.
So agonists are the good keys, the ones that are designed to turn the lock and start the engine.
Right. They mimic the body's natural key perfectly. Insulin is the classic example. It's an agonist because it fits into insulin receptor sites and tells the cell to let glucose in, just like your own natural insulin would.
But then you've got the blockers.
Then you have the blockers, the
Yeah.
antagonists. And we have two main types. The first is a competitive antagonist.
It competes for the same spot.
Competes for the same lock. It fits, but it doesn't turn. It just sits there, blocking the body's natural key from ever getting in. The classic example is Curare, the poison.
Oh, the poison dart stuff.
That's the one. It blocks the receptor for acetylcholine so your muscles never get the signal to contract. That's paralysis.
And the other one, the non-competitive antagonist, that one sounds sneakier.
It is. It gets the same result, blocking the action, but it does it by attaching to a different spot on the same cell. It doesn't compete for the main lock at all.
So it changes the shape of the lock from the side?
You've got it.
Right.
It causes a structural change, so the main key won't fit anymore, even though the keyhole itself is technically empty.
And beyond these receptor sites, drugs can also just throw a wrench in the works of the body's machinery.
They can. Specifically by blocking an enzyme. Think of it like a factory assembly line. If you block one single step, one enzyme, you can shut down the whole production cascade that comes after it.
Now, when we're talking about, say, antibiotics, the goal is totally different. You want to hit the invader, and only the invader.
Yes, that's the holy grail. It's called selective toxicity. The drug has to be a guided missile, attacking a system that only exists in the foreign cell.
Like penicillin.
Penicillin is the gold standard. It attacks an enzyme system that's unique to the bacterial cell wall. Our cells. Well, they just don't have that system. So for us, the toxicity is incredibly low.
But that's not always possible, is it? Especially with something like cancer.
No, absolutely not. Many cancer drugs work by a brute force method. They destroy any cell that's reproducing rapidly. And yes, that kills the tumor, but the collateral damage is immense.
Which is why people lose their hair, have GI issues.
Exactly. Because those are areas with healthy, rapidly reproducing cells. Your GI tract, your hair follicles, your bone marrow. In that case, selective toxicity is, well, it's sacrificed for the sake of efficacy.
Okay, so that's the drug's plan. But here's where the body takes over, pharmacokinetics.
Right. This is the journey. It's often abbreviated ADME.
ADME.
Absorption, distribution, metabolism, and excretion. This is what decides your dose, your timing, everything.
And the whole point of managing this journey is to achieve what we call critical concentration. That's the magic number. It's the minimum amount of drug you need in the target tissues for it to actually work.
And if you need it to work right now,
Then you use a loading dose, a big upfront dose to get to that critical concentration as fast as possible. We do this with drugs like digoxin for heart failure. You hit them hard first, then you back off to a lower maintenance dose.
All to maintain this balance, this dynamic equilibrium, where all four of those ADME processes are constantly at work. So let's start with A, absorption. Absorption is everything from the moment the drug enters your body until it hits the bloodstream. And the route you take is everything.
Oral is safest.
Safest, but also the slowest. An IV, on the other hand, just bypasses absorption completely.
It's straight into the veins.
Straight in, immediate effect, full strength, which is great in an emergency, but it's also incredibly dangerous. There's no recall button, no time to fix an error or a sudden allergic reaction.
And for a simple pill, what's the biggest hurdle it has to get over?
The acid in your stomach, it's a killer. And food, especially protein, makes the stomach produce more acid, and it also slows down how fast the stomach empties.
So the drug is just sitting in that acid bath for longer.
For much longer, getting broken down. That's why the ideal timing for many oral drugs is 1 hour before you eat or 2 hours after. You want to get it through the stomach and into the small intestine as fast as possible.
And once it's there, how does it cross over into the blood?
Mostly through something called passive diffusion. It's the main process. It doesn't take any energy. The drug molecules just move from an area of high concentration to low concentration.
So it's all about how fat-soluble the drug is.
That's a huge factor. Fat-soluble drugs slip through cell membranes like butter. There are other methods like active transport, but they become more important later in the journey, especially for getting things out of the body.
Okay, moving on to B, distribution. Getting the drug from the blood out to the tissues. This sounds like where things can really go wrong.
Oh, absolutely. Distribution is all about blood flow, or what we call perfusion. If an area has poor circulation, the drug might never get there in a high enough concentration.
Like a diabetic patient with a foot infection?
A perfect and very common clinical example, or even just someone in a cold environment where vasoconstriction reduces blood flow to your fingers and toes. A systemic drug might just fail to reach the target.
And what's the big traffic controller in the bloodstream that determines how long a drug sticks around?
Protein binding. This is a huge concept. For a drug to be active, it has to be free and unbound in the plasma. But many drugs grab onto proteins and hitch a ride.
So if it's tightly bound, it gets released slowly.
Very slowly, which gives it a long duration of action. The danger, though, is competition. If you take two different drugs that are both highly protein-bound,
They fight over the limited seats on the bus?
they fight for the seats, and one drug can get kicked off the protein, which suddenly spikes its free active concentration in the blood.
And that's how you get toxicity, like aspirin knocking methotrexate off its protein.
Precisely. All of a sudden, you have a dangerously high active level of methotrexate floating around. It's a classic interaction.
And the body has one final ultimate security gate, the blood-brain barrier.
It's the ultimate defense. It's incredibly selective and really only lets highly lipid-soluble, fat-soluble drugs pass through into the brain.
Which is why treating a brain infection is so hard.
Notoriously difficult. Most of our best antibiotics just can't get past that barrier. The only time they can sometimes get through is if the infection itself is so severe that it actually damages the integrity of the barrier.
All right, next up, the body's detox center. C, biotransformation, or metabolism, the liver's big moment.
This is its star turn. The liver is the single most important site for this. It's like the body's sewage treatment plant. Its job is to take active drugs and change them into less active, more water-soluble chemicals
So they can be flushed out.
so they can be excreted. And the key process for any oral drug is the first-pass effect.
This one is so important.
It's critical. When you swallow a pill, it's absorbed from your GI tract and goes straight to the liver through the portal vein system. And there, a huge chunk of it can be metabolized and inactivated before it ever gets a chance to reach the rest of your body.
And that explains everything about why an oral dose can be, 10 times higher than an IV dose of the very same drug.
That's the entire reason. The liver is just this incredibly effective filter right at the start, and this is all driven by the hepatic enzyme system, specifically a family of enzymes called cytochrome P450.
And that system can be manipulated?
It can. You can have enzyme induction, where another chemical speeds the system up, making it chew through other drugs much faster, maybe even making them ineffective.
Or the opposite?
Or the opposite, and this is often more dangerous, enzyme inhibition. A chemical slows the system down, which prevents the breakdown of other drugs.
Which leads directly to toxic accumulation. So that brings us to the final step, excretion, getting it all out.
Primarily the kidney's job, but also the lungs, bile, even your skin. In the kidneys, it's a two-step process of filtration and then active transport. But Here is probably the single most important safety check in all of this.
Okay.
You must always check a patient's liver and kidney function before starting a new drug regimen, period. If either of those organs is impaired, the body can't clear the drug. Toxic levels are not a risk, they're a guarantee, it is non-negotiable.
So if ADME is the journey, then half-life is the schedule on the train ticket.
That's a great way to put it. Half-life is simply the time it takes for the amount of drug in your body to decrease to 1/2 of its peak level.
It's the result of that whole dynamic ADME equilibrium we talked about.
Exactly. So if you take a 20 milligram dose of a drug with a 2-hour half-life, after 2 hours, you have 10 milligrams left.
After another 2 hours, so 4 hours total, you've got 5 milligrams.
You've got it. And this is why sticking to a dosing schedule is so important. It's all designed around the half-life to keep you in that therapeutic range. And it's also why we say it takes about 5 to 7 half-lives for a drug to be considered fully cleared.
So it's clear the process is complex, but then you add the biggest wild card of all, the person.
The human variable. No two people handle a drug in exactly the same way.
I mean, we know that standard doses are usually based on a 150-pound person, so weight matters. But what about age and gender?
Age is huge at both ends of the spectrum. Children have immature systems. Their liver and kidneys aren't fully developed. And older adults, their systems are just less efficient across the board. Slower absorption, slower metabolism, reduced kidney function.
So they're both at high risk for toxicity.
Extremely high risk. They often need lower doses and much closer monitoring. And gender can play a role too. Men tend to have more vascular muscles, so an IM injection might absorb faster. Women, on average, have more fat cells, which can hold on to fat-soluble drugs for longer, prolonging their effects. Think about certain gas anesthetics.
And then we get to what is maybe the most dangerous variable of all, interactions. We touched on drug-on-drug competition for proteins, but I want to talk about that one food interaction everyone has to know.
You have to mean grapefruit juice.
The famous one.
It is the classic high-stakes example of enzyme inhibition. Grapefruit juice. And it's not the acidity, it's specific chemicals in the juice.
Right.
They actively interfere with that cytochrome P450 enzyme system in the liver. They just shut it down.
And the really scary part is how long that effect lasts. It's not just if you take them together.
Not at all. The effect can last for up to 48 hours. So drinking juice in the morning can still affect a pill you take that night. And if you're on, say, a statin like atorvastatin, which needs that system to be broken down,
The levels just build and build.
they build up to toxic levels, putting you at risk for really severe side effects like muscle breakdown or rhabdomyolysis. So the advice isn't don't take them together. It's do not consume grapefruit products at all the entire time you are on that medication.
Wow. And just a quick note on one last type of interaction.
When a drug messes with your lab tests,
Yes, drug laboratory test interactions. It's just when a drug can alter a diagnostic result, maybe giving a false clinical picture. For example, the anticoagulant dalteparin can sometimes make liver enzymes on a blood test look artificially high, even when there's no actual liver injury.
so you always have to look at the patient, not just the paper.
Always. Does the lab result match the person in front of you? What an incredible density of information. So just to recap, we've covered the 4 ways drugs act, the dynamics, and the body's 4-part process for handling them, the kinetics, ADME.
And the overarching takeaway is just this. Every single dose, every schedule, every safety check, it all comes from that fundamental balance. And the focus has to be on the individual, on their unique factors, and especially on their liver and kidney function.
And that leads perfectly to our final thought for you to chew on. With the incredible rise of pharmacogenomics, which is the study of how your personal DNA dictates your response to drugs, we're seeing a shift away from that one-size-fits-all 150-pound person model.
We absolutely are.
So the question is, how soon until drug regimens are completely personalized, right down to the specific enzyme signature in your liver?
It's already starting. We're getting to the point where we can do a genetic test and predict, with pretty good accuracy, who will be a fast metabolizer of a drug like warfarin and who will be a slow one. And we dose them based on their genes, not just their weight. We really are on the cusp of true precision medicine.
Truly fascinating stuff. Keep diving deep.